So I'm James Murrough. I'm Vice Chair for Clinical Research in the Department of Psychiatry at the Icahn School of Medicine at Mount Sinai. I'm also Professor of Psychiatry and Neuroscience, and I'm the Director of the Dennis Charney Depression and Anxiety Discovery Center at Mount Sinai.
So, hi everyone, my name is Emma Guttman, and I'm the chair of the Department of Dermatology at the Icahn School of Medicine at Mount Sinai as well. I wear several hats at Sinai. Besides running the department, I have a big lab that focuses on inflammatory skin diseases. I do clinics and I also direct some clinical trials. And we are very involved in the inflammatory skin disease space and also skin cancers, but our claim to fame is the inflammatory skin disease space. So maybe I'll start and tell you
Yeah.
how this study even started. And, I always say that the best studies are done by collaborative teams like this one, because that's when discoveries are happening. And, in dermatology, we now have what I call a translational revolution. And for a while, even though I'm not a psychiatrist, but I must tell you a secret, I was debating between psych and derm. And at
I
the
don't
end,
think I knew that.
yes, I
Okay.
myself had atopic dermatitis growing up, and I think that's what trumped it at the end.
Uh-huh.
But I love the psych area as well, and I have many friends that are psychiatrists. And I always thought that that revolution should get there as well. But I think you actually came to me, and I think you saw that in psychiatry, in patients with depression, with intractable depression, you started to notice some increased inflammation in their blood. And
Yeah.
then I think because what they have done, they looked only at few cytokines. They didn't look broadly at cytokines. And they saw that some IL-17 related cytokines were increased. And they were thinking to compare to psoriasis. And I'm glad I had the idea, why not compare to both eczema and psoriasis that are different poles of the immune system, and also look broadly at multiple immune molecules. And I'm glad I did that, because while IL-17 is slightly increased, we found actually that type 2 cytokines like IL-13 and others are much more increased in depression, very similar to eczema. And then we did that innovative study, putting the phenotype of Dupilumab and what Dupilumab does in patients with eczema. We basically transposed it on the psoriasis, on the depression patients, and we managed to extrapolate that if Dupilumab would be given to depression patients, it may reverse potentially 100% of the phenotype, which is right a novel thinking that a safe biologic that doesn't really have side effects can be potentially given to psoriasis patients. And we need to also, I keep saying psoriasis, to depression patients. And we need to remember that eczema is also associated with depression. So, and
Right.
we never know what's the chicken and what's the egg. So there might be, this can be something that we will continue to collaborate, because people don't think about the fact that maybe that depression component in eczema may have some other associations and vice versa. So there might be different crosstalks that need to be explored, but I think for depression, this may have a very important meaning, that it may change the treatment paradigm.
Yeah. Thanks, Emma. Um, picking up on that point, um, in depression, there's been suggestion from research for many years, really, that there's some inflammatory component, but the state of the field right now is we're just not exactly sure what that is. There's a question mark of, it's likely that people that have depression might not have exactly the same underlying biology. It might be that different perturbations in the immune system are relevant for the treatment of different subpopulations of patients. In it's kind of the state of the art in psychiatry right now. Um, Depression, major depressive disorder. This is one of our most common and disabling illnesses in psychiatry. We don't fundamentally know the causes. We know that stress is a big factor. We know it's partially genetic, and the way that someone's genes interacts with the environment is a major driver of this. We know that some of the neurotransmitters in the brain that have been studied for a long time, like serotonin, that are the target of current treatments have a significant role. But in the past decade or so, more and more, it's also, besides those neurotransmitters in the brain, implicating inflammation. Interestingly, so there can be inflammation that originates in brain, and but also part of what we've found and others is that actually inflammation that at least starts in the periphery may have a very important role. At least some people that have depression, um, and to Emma's point, we know just from epidemiologic studies that illnesses like inflammatory skin diseases, other types of inflammatory disorders like rheumatoid arthritis, they co-occur with major depression at rates that are higher than you would expect from chance alone. Um, in basic neuroscience, behavioral neuroscience study, for example, looking at the effects of inflammation in mice and things like that, if you induce inflammation, they exhibit features of depression that we can measure. Um, and detailed studies done by, for example, our close collaborator on this work, Scott Russo, who's in neuroscience here, who directs the Brain Body Institute. Some of that work showed early on that stress, psychosocial stress in animals, but also now it's been shown in people, increases immune factors in the blood. And then, at least in animals, those immune factors can actually traffic from the body, from the periphery in the blood to the blood-brain barrier, and then through various mechanisms can either cross in or send signals that then induce a reaction in the brain, which ultimately negatively regulates the brain systems and circuits that in psychiatry we think are really important for mood. These are systems in the brain that help support people learning from positive information, or so-called a hedonic response, or things like that. So, I think we've gotten to a point where we're now, there are several hypotheses and a fair amount of data to suggest different ways that the inflammatory system and the immune system may be interacting with the brain to cause some psychiatric disorders. And that's relatively novel thinking. And then this study we sort of took a unique angle working with Emma and her team, which is to say, okay, if there are signs of abnormal inflammation in the blood in people with depression, in what way does it look like other diseases that we know, in some ways, we know more about its fundamental biology, and there are potent, effective treatments? And what can we learn about how we can develop treatments that are more effective in depression? So it's kind of that logic and I think this study that we're discussing is sort of an example, and it gives us a certain direction, a specific target to go after, which we will, but also just illustrates a broader way how we're thinking about kind of the future of psychiatric research and treatment.
Yeah, no, this is so exciting because you didn't hear yet, but James got a nice grant to actually pursue this study with Dupilumab, and we are hoping that he'll also get the drug, hopefully.
Right. Yeah, exactly. So sort of building on, um, as Emma said, building on our findings, it did implicate actually a specific candidate that should interact with the biological pathways in a way to normalize the abnormal immune signature that we observed. And so it's sort of set ourselves up to do, now let's actually try giving the drug to, in this case, it's Dupilumab, um, which has never been studied before in individuals that don't necessarily have a frank inflammatory disorder, but in fact they're suffering from major depression. Does an immune targeted drug like that, can that help those people? And so we're using Dupilumab as essentially a tool compound, an example. Sometimes we call it a repurposing strategy. And so hopefully over the next year or two, we'll be able to conduct a small study to see if Dupilumab improves symptoms of depression, changes the immune signature in the blood in a way we might expect, and even whether it can modulate some of these brain circuits that are important in depression that we can actually measure in in people using non-invasive neuroimaging tools like functional MRI. That was funded by the Wellcome Trust, which is wonderful. So we're excited about that. So we'll know if we're onto something in the next year or so, hopefully. My dream would be, if you're suffering from depression or one of these common psychiatric illnesses, you go see your doctor. They're going to take a careful history. They're going to ask you when your symptoms started. They're going to ask how it's impairing your life. In the current diagnosis of depression, that's essentially where it ends in terms of getting the doctor getting the data to make a treatment decision. But we want to augment that with the doctor can order a blood test and figure out what type of treatment you might respond to. Currently, that really doesn't exist. And to your point, we think that the immune system might be a good candidate for eventually the development of a point of care blood test, because blood is readily accessible. If it was a brain signal you needed, that might be more difficult, although those might be very important also. And we're actually pursuing those as well. But a blood test would be a good candidate to pick up an inflammatory measure in the blood that would then inform which treatment do you need. We're not there yet, but that's where we want to go. And I think part of what this study in collaboration is kind of helping us to think about. It's probably not, is there an inflammatory subtype of depression or not? Although that may be a first pass. That's an active area of discussion and research also. But there are probably, the immune system is probably gone awry in different ways in different people. So I think that the future is going to be, how do we match? Ultimately, what we want to do is we want to match treatments to patients so that it's much more likely that the first treatment a doctor prescribes, the person's going to respond to. In psychiatry, we have trial and error. Now, that may sound a little bit discouraging, and in some ways it's not where we want to be. But what it means is we have a lot of data comparing, knowing on average how people with depression or other conditions, whether they respond better to drug A versus placebo or drug B versus placebo. And then we have all these treatments, right, that have FDA approval for depression. But ultimately, we still don't really have measures to tell us which medicine is for what patient. That's kind of where we're trying to move to.
Yeah, it's very exciting. And from my perspective, I think to develop a successful biomarkers, you need to do that through trials. So I think they will see what biomarkers may be possible from that study with Dupilumab and other
Right.
drugs of this kind.
Yeah, exactly. So people say, well, how come my doctor doesn't order a blood test for me to know which antidepressant? And again, they would if there was one that has been shown to be effective. Now, I should say there are some tests your doctor can order, looking at how drugs might be metabolized in your body. That's a little bit different, but that could be relevant. But in this case, what we're talking about is, like, again, in so many areas in medicine over the last number of decades, we've moved to kind of a broad diagnostic category that's based largely on symptoms, or what we call clinical presentation, and moved to sort of biologically defined subtypes. And that's kind of where psychiatry is. That's where our research program is focused. But we're not there yet. And we actually there's not one single example in psychiatry of a biologically defined subtype of a psychiatric illness. And it's very, very likely that what we call major depressive disorder, which is clinically defined if you have persistent sad mood, fatigue, low energy, inability to respond to pleasure for many weeks, and it causes functional impairment, you get the diagnosis. But it's likely that people present that way, but under the hood, so to speak, you have different things going wrong in different ways. Maybe someone has a serotonin abnormality, and they would benefit best from a medicine that targets serotonin. Another one, norepinephrine. Another one, some aspect of the inflammatory system. Another one, maybe a different aspect of the inflammatory system. That's kind of how we're thinking of it.
No, it's so fascinating, and I think Right now, the study is positioned for people with severe depression, but in the future, who knows if it's effective? Maybe it will be offered even early on. Why would you need to suffer severe depression? At least in the skin, I'm thinking about
That's right.
this way, and I think everywhere it should be this way.
Yeah, yeah. And that kind of comes down to sort of when in the algorithm of treatment does the doctor order a test, like a next test? So sometimes you have medicines like first line antidepressants these are the so-called SSRIs, serotonin selective reuptake inhibitors. They actually work for a fair number of folks. And it could be that sort of a cost benefit would say, look, if you have your first depression, you go to your doctor, it might be most cost effective and appropriate and like less need for invasive, expensive tests just to try that. But
Mhm.
then, and if you respond, great. It's kind of that group. But then if you don't respond, then Emma, that's where we sort of get into like, can the
Exactly.
doctor orders. So, but that's kind of, we'll have to see, right? Where does that, at what
Yeah.
point do we order a brain scan, for example, a blood test, things like that. But I will say, Jessica, going back to your question, um, there's discussions right now. I mentioned the DSM, that's the Diagnostic and Statistical Manual for Mental Disorders. Um, we're on the fifth edition, and there are working groups to develop the next edition. And one of the things they're talking about for DSM 6 is defining a inflammatory subtype of depression, whether there's enough data now. Um, so it's a very active, very exciting, very active. And one of the things that we'd be looking at for that is that, is there data that it's a unique biological subtype? Is there treatment implications? Because ultimately, what's the point of all these diagnoses we have in medicine unless it tells the doctor how to treat the patient, right?
Definitely.
Uh, yeah.
So we already, I think, as dermatologists are thinking about, in general, many skin diseases are associated with depression, but primarily atopic dermatitis, but not only. We know that psoriasis, for example, is also associated with depression, and so is alopecia areata. A lot of it, and James and I talked a lot about it, maybe what we call in dermatology reactive depression, but he says that reactive depression has also something behind it.
Hmm.
Mm, But, for example, if you have alopecia areata, of course you'll be depressed because, it's not nice when you don't have hair all over the body, right? It's how the society views you, how you view yourself. In atopic dermatitis, if you have moderate to severe disease, many times you'll not sleep at night. So when you don't sleep, you're agitated.
Yeah.
Uh, so of course that will change your mood and so on. So I think there are many relationships and we need to learn more about these.
Yeah. And I think just picking up on that, I think one of the things that Em and I have been discussing is I think there is a tendency for doctors outside of psychiatry to think of sort of co-occurring depression and anxiety as like the term that Emma used there, reactive, which just for people to know, which what I think you mean is it's like a psychological response to
Exactly.
the disease they have, right? Is that because
Primary disease they have, that is the eczema, the
and
so
now I'm depressed because I have this.
exactly
And
how we are used to think about it.
that's right. And I think one of the things we've talked about, and maybe Jessica, to your point, like we may want to push our colleagues outside of psychiatry to think a little bit because it turns out maybe like we talked about at the beginning, actually there may be shared underlying pathophysiologic mechanisms relating to the immune system or others that would actually explain this co-occurrence. But I don't think many doctors don't think of it like that. And it has implications. Like, for example, the doctor who assumes the depression's reactive, um, again, all these medical decision making or reasoning, then the treatment implication there is you would focus on treating the primary skin disease or whatever it might
Not
be.
send the patient to a psychiatrist, which the patient may benefit from a
That's what I'm.
co-administering
That's
something.
right. So I think this fits into a broader kind of. We try to educate our non-psychiatric physician colleagues to, yeah, maybe have a lower threshold to refer for mental health screening or treatment, and sort of not fall into the trap of saying, well, yeah, I'd be depressed too if I had that. And as long as I can treat their condition so that they'll get better, maybe not. And I think that is an implication, Emma, right? That maybe have a lower threshold. And at the systems level, and I think this is reflective of many healthcare systems across the country. I think everybody gets depression screening that comes through the door, if not annually, for their primary care checkups in the health system here, maybe when they come to derm. So there has been a lot of work in standardizing screening, which just helps both to remind patients to bring it up with their doctor, right? Don't forget, patients may not even think to bring it up or be comfortable. So we're trying to build things in that will help detect depression in our patients that are seeking general medical care and others and surgical care for early screening and intervention if appropriate.
I completely agree. So, of course, not only the efficacy, but I think the safety is very important. But the beauty of the biologics from the atopic dermatitis world, they are much safer than biologics going into GI or other things. So I think I would say we don't have a lot of barriers because we have really amazing safety in these biologic treatments in atopic dermatitis that can easily be translatable. But